And now it's my chance to introduce our speaker. So today we're very fortunate to be joined by Victoria Seville-Klein. Victoria is a clinical ethicist in Alberta Health Services Central Zone and a clinical lecturer with the Doster Health Ethics Center. Prior to working with AHS, she was the ethicist and policy director with the Provincial Health Ethics Network, also known as PHEN. Victoria holds a PhD in philosophy, specializing in bioethics from Dalhousie University, and an MA in philosophy ethics from the University of Calgary, and a BA in philosophy from the University of Victoria. She completed a clinical practicum in multiple health ethics centers in Halifax, Nova Scotia, and a doctoral fellowship in ethics of health research and policy through the Canadian Institute of Health Research, and a postdoctoral fellowship in clinical and organizational ethics at the Joint Centre for Bioethics at the University of Toronto. Without further ado, I'm now going to pass it over to Victoria, who will be speaking on the topic of sexuality in care facilities.
Thank you very much, Michael, and thank you for inviting me to be part of the series. I also want to acknowledge the very difficult times we're all facing right now in Canada, especially those of us in Alberta right now. So I just want to really appreciate your time in attending the session today to address this topic. I don't have any conflicts of interest. My hope today is to increase awareness of sexual expression across the lifespan and to appreciate the barriers of sexual expression in care facilities. I'm going to particularly focus on people as they age or develop a cognitive impairment, although my comments will extend to people of other physical impairments and the younger adults that we also know live in care facilities these days. I would like to reflect upon decision-making in more challenging ethical scenarios and hopefully provide some future directions for addressing this topic. A note specific to COVID-19 on this topic, as we know, COVID-19 has introduced a number of restrictions in our abilities to be social and to engage with others. Sexuality in care facilities has been a topic and is worthy of discussion preceding the pandemic. So I'm not going to focus particularly on pandemic restrictions in this presentation. What I do hope, though, is our own experience of isolation and being and physical distancing and being apart from loved ones may help us have a personal experience of what of the importance of intimacy and touch has for people living in our long-term care facilities and continuing care facilities across the country. So I'm going to give you a bit of an overview of sexuality across the lifespan and some of the importance and barriers that individuals may experience. Some of the challenges I'm going to focus on particularly involve people who have diminishing cognition, the challenges of involving family members and substitute decision makers, and how we respond when values, beliefs, and preferences may change over time. And then I'm hoping to leave you with some thoughts for how care facilities and we as a society might help to address the situation going forward. I think it's important to keep in mind that people that we're talking about are real people with real feelings and needs, even though many of us may be approaching this more from an outsider perspective. So I thought in terms of hearing an overview about sexuality from our elderly, members of our society, that it would be important to hear from them directly. So I'm going to share this short clip. You may need to turn up the volume on your headset a little bit to hear it. And I hope you keep in mind what's important to them about sexuality and intimacy.
Do you want? The most romantic thing is the moment when I ask her, do you want to go to bed with me?
The first time I said no.
So a few days later, I asked her again, and she agreed. This was the most romantic, wasn't it? The most romantic thing. My name is David Bielobroda.
My name is Ruth Cooper, and my age is 79.
I was born in 1980.
My age is 92.
My name is Sunga Greisman Rubin, and I'm 84.
Going on
Gee,
85.
how old am I?
Well, I truly believe you stay young because of sex.
At 18, we just wanted a sex object. At 75, you may still want sex. You're not sure you're going to get it, but you're looking for comfort.
I've always wanted romance in my life. Really love, you know, and I think you need it all your life. You need it all your life. You need to be touched. You need to be felt. You need to be hugged. You need to be kissed.
Companionship is very important.
So we cover it up with, well, I don't need men in my life, and I'm past my desires. Baloney. I don't think you ever get past your sexual desires.
I adore it, and I'm not ashamed of it.
Yeah, he doesn't look it. He's a very sensual man.
Very.
Listen, I've had so many boyfriends, I can't even count them on my fingers and toes.
Most of the men my age or better are either dead, looking for a nurse or a purse, or sick.
I'm short, reserved, self-conscious, eager to please. I'm compassionate, a good listener.
I used to always look for a good-looking man and good dancers. That's what counted. And dress well. Oh, God forbid they shouldn't dress
She
well.
would be a non-smoker.
Yes, pretty, beautiful also.
He has to have his shit together.
Kindness, consideration.
Sparkle in their eyes.
That tips well.
And no Republicans, please.
But there is something about a senior citizen community that you realize that you are mortal, you know? You see too many people around you, and you know that someday you're going to say bye-bye too.
Unfortunately, I've outlived just about every one of my friends.
You know, at this age, there isn't much time for independence. You know, you think there's just a few years left, and you want to do as much as possible togetherness.
When my husband died, he was 52. I took off my wedding ring, and I said to myself, I wonder what's around the corner for me. And I think instead of sitting and saying, oh, he died, I always looked forward.
The person in my age who has the capacity of doing sex, this is the highest thing in the world, the greatest achievement in the world. And the pleasure is unbelievable.
This business of saying a man uses a woman for a one-nighter, what about a woman using a man? Is that terrible? Kushner and Tuchasarai. You know what that means? I hate to tell you. Kiss my you-know-what. It is, when you say it in English, it sounds bad, right? But in Jewish, it's kind of cute. And someone says something to you, you say, yeah, Kushner and Tuchasarai, kind of cute, you know?
Hey, so I'll stop it there, but I hope that was a nice explication of some thoughts of some of our seniors about their sexual interests and sexual expression. And what I'm going to do throughout this presentation is show you some additional quotes of residents who are living in care facilities right now in Alberta, just so we can keep their voices included. The World Health Organization defines sexuality like this: as a central aspect of being human throughout life. It encompasses sex, gender identities, and roles. Sexual orientation, eroticism, pleasure, intimacy, reproduction. It covers a range of kinds of sexual expressions, including desires, attitudes, behaviors, and beliefs. And importantly for us in our conversation today, this last bullet about sexuality, while it can include all of these dimensions, not all of them are always experienced or expressed. And this is because, because sexuality is influenced by a range of other kinds of factors like psychological, economic, political, cultural issues. And I think this is important for us because long-term care facilities are essentially a microcosm of society where different beliefs and values may come together and affect the ability of residents to express their sexuality. So in terms of occurrence, we do know that sexual activity and desire does continue as people age across the lifespan, although it does decrease in frequency from about the mid-50s and more so in women than in men. And in this other second large study that has been done in this area does also show that there is a decrease in frequency and diversity of sexual activity over as people age. Although the numbers are higher when we look at non-partnered activity. And this study actually went up to the age of 94. The data that I just showed was about sexual activity, but we, as I mentioned before, sexual expression encompasses a broad range beyond just sexual activity, including being flirtatious, feeling attractive, how you dress, holding hands, seeking of intimacy. So here's a quote from one resident in Alberta. It is unanimous in the literature that all the benefits of sexual expression do apply to this whole range of sexual expression, that it does affect health and well-being. So sexual activity has the benefits listed here: reduced weight loss, reduced risk of heart disease and stroke, pain relief, improved mood. Sexual expression and affection can also help with pain, relaxation, lower levels of depression, and love and intimacy also can contribute to longevity, mental health, self-esteem, quality of life. I think the importance of sexuality, it also does go beyond health and quality of life to our sense of place in the world. So some researchers have written about the connection to safety and well-being. So again, here's another quote from an Alberta resident, or a family member in this case. And again, very important to us in terms of people as they may develop cognitive deficits is this very central connection to personhood and identity, which we're going to come back to through this presentation. Along with the benefits that we just talked about, there are some risks. Some of the straightforward physical risks are sexually transmitted infections, which we do know occur with people and older adults. For those in care facilities who do have many younger adults, as we have more these days, obviously there's the risk of pregnancy. Falls might occur for people who are more frail or have mobility issues. Abrasions can occur with genital stimulation if appropriate lubricants aren't used. There are also emotional or social risks. So there are emotional risks with any human relationship. Social risks may apply to people who are in a care facility if they still have relationships outside the facility in the community with community partners or just with their family members. And I think this is inherent in the fact that people in care facilities are inherently in a more communal space. And so there are going to be more occasions where their private choices and sexual expressions interact with other people. Abuse and exploitation are particularly of concern for people involved in this topic. Particularly with concern with lack of capacity, the worry that people may be subject to unwanted sexual behaviors. There is obvious evidence that there is sexual abuse by and to people with dementia. We do know it's underreported, although the data is quite hard to gather because usually sexual abuse is lumped in a general category of elder abuse, and so it's not easy to pull out. And we also know it's highly underreported. Some more recent studies have shown that where sexual abuse has been noted in care facilities, that it tends to be perpetrated by staff or unintended visitors as opposed to other residents. And this last point about violence is a reflection on the growing evidence that care facilities tend to be heterosexual or heteronormative. And our Canadian data shows us that gay, lesbian, and bisexual people are 2 times more likely to experience violence as heterosexual individuals. And so there have been fears expressed by the LGBTQ as positive communities about harassment or discrimination in care facilities. The World Health Organization again gives this definition of sexual health, which is a state of physical, emotional, mental, or social well-being in relation to sexuality. And it includes having a respectful, positive approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences. This last point is emphasized twice in the sense that for sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. So all persons is significant because it's not specific to cognitive status or physical ability or age or any other area where we might typically talk about discriminatory attitudes such as ethnic background or sexual orientation, and also the fact that sexual rights are discussed. And rights impose additional obligations on people to try to uphold those other than where we often talk about sexual expressions in terms of a human need. As a throwback to your early psychology days, if you took this in your early studies, this is Maslow's hierarchy of needs, which identifies when our most basic needs need to be met before people can be motivated to by these higher level of needs. So as you'll see, sex is down here in this basic level of needs. And while in care facilities, staff are excellent at addressing kind of hydration and nutritional needs and sleep, we're less good often at addressing residents' sexual needs. So up to this point, we've talked about how sexual expression is a human right and it's essential for health and well-being, that sexual desire exists across the lifespan and does continue. And yet the rates of sexual expression in care facilities are 3 to 4 times lower than in equivalent populations in the community due to a number of barriers, which we'll talk about now. And it does result in a lot of confusion and distress, both for care providers, for residents, and for family members. So what are some of these barriers? One are just general stereotypes around age. That in our society, youth is often associated with beauty. So people as they age are often considered asexual or not interested in sex or undesirable. Many treatments for common conditions are associated with sexual dysfunction. So this includes diabetes, hypertension, cardiovascular disease, cancer, anxiety, and depression. And many sexual relationships end because of the poor health of the male. And research shows us that most sexual activity occurs in long-term relationships. And in that study I quoted earlier, in that 75 to 84-year-old category, 72% of men and 39% of women had a partner. So in heterosexual relationships, that's because women tend to have a longer life expectancy than men and marry older men. So they tend to be alone without their partner for more years at the end of their life. For people with dementia in Canada, this graph shows the difference in the proportion of female to males, both in the community, in their own households, and in institutions, in care facilities. And you can see that in that 80 to above 80 category, that the portion of women is much, much higher than men, which is of course relevant if you were of a heterosexual orientation. One of the most significant barriers to sexual expression in people as they age is the environmental constraints imposed on residents by virtue of being in a care facility, presumably often because they're set up to be very open and communal. And doors often either don't have locks or they're discouraged from use. Often doors are kept open. There are single beds. Sometimes people are still in shared rooms. And there are very few policies internationally around addressing sexual expression in care facilities, which tends to result in staff being overcautious or an interventionist when it comes to sexual expression of residents. Just give me a sec to read that. Additional barriers are the attitudes of staff and family members. So obviously staff are part of society, so many of those stereotypes I talked about earlier are shared among staff and of shared care facilities, that residents as they age are asexual or disinterested in sexual activity. Often sexual behavior is ignored or treated as a behavioral problem. And this is particularly the case with residents with cognitive impairment. There also tend to be more negative attitudes towards people outside of heterosexual relationships. And this has resulted in fears that I alluded to earlier of people from homosexual relationships or transgendered being afraid of discrimination in facilities, or being afraid to rely on others to help them dress, for example, or feel that they'll have to hide their sexual orientation when they go into a care facility. For family members, typically are accepting more minor or less physical interactions, but are less accepting of more erotic or sexual interactions, although that varies much more widely across different kinds of families. The general summary of all the literature on this topic about attitudes of staff and families is that companionship between residents is encouraged, romance is frowned upon, and sex is taboo. There are particular challenges and barriers with people with impaired capacity. So that's what we're going to talk about now. In Canada, 45% of people who are over 45 years old in long-term care have dementia. Although they do continue to be sexual beings and want to express themselves sexually. This has been a challenge for several reasons. One is historically, people with dementia, their sexual behaviors have been considered subdimensions of aggressive or agitated behaviors, or seen as problematic or inappropriate examples of disinhibited, hypersexual, or aggressive behaviors. Their behaviors can also be misinterpreted as sexual when really it's a desire for intimacy, or they're reaching out for connection or wanting touch. Or the progression of the disease may cause them to misinterpret the behaviors of others. For example, misinterpreting a caregiver helping them to undress, or washing them or bathing them, as well as misinterpreting appropriate locations for sexual activity, or misidentifying a partner. Sexual expression by people with dementia, it tends to be less supported by staff based on comments I've made earlier. There's this connection between cognition with moral permissibility. So because people where they have decreased cognition, there's a concern that that somebody may be subjected to unwanted sexual behavior, and therefore there's concerns of abuse, and there's a tendency to separate. And this has resulted in what we might call a paradigm of protection, where in order to protect residents with dementia from unwanted sexual behaviors, this actually results in sexual expression being prohibited more broadly. The other challenge with people with dementia is, as their disease progresses, they may actually exhibit different kinds of preferences or values or behaviors than they did earlier. And this can include expressing sexual orientations that may have been repressed earlier. So we're going to take a closer look at decision-making in some of these challenging scenarios. First, generally, as with any situation in healthcare, we respect the choices of capable residents, which includes their decisions about how they want to express themselves sexually. And just because residents are in a care facility doesn't mean that one should inform family members or have discussions about their sexual choices, either within the facility or with those family members. So it's important to recognize that choice, or that autonomy to make their own decisions, also comes with some obligations to privacy. Capacity is also decision specific on a continuum and can fluctuate. So even if somebody is generally incapable and, for example, has a substitute decision maker in place, they may still have the capacity to make decisions about sexual activity. Capacity for sexual activity has been defined most commonly in the following ways: as having basic sexual knowledge, so of anatomy, what sexual interactions might involve, understand possible consequences, both for themselves and for another, such as a partner, the ability to understand appropriate and inappropriate locations and times, and the ability to express a choice and resist coercion. And it's important to note that this expression can be either verbal or nonverbal. and the ability to recognize distress or refusal in a partner. Importantly, these criteria don't preclude sexual activity if they're not met, but it means that it might require some assessment to ensure that there is no risk posed that would be untenable, or that can to see if any risk could be mitigated in some way. So for individuals who are incapable for decision making, how would we normally respond? Typically, what we would do in healthcare is involve substitute decision makers, and their role is to represent the known wishes, values, and beliefs of the adult, including the adult in decision making as much as possible. And there are lots and lots of challenges for this model when it comes to sexuality. First of all, sexuality is atypical. It's not like other kinds of healthcare decisions. First of all, you can't consent on someone else's behalf. Consent to sexuality has to be in the moment by that person, and you can't provide advanced consent. So it's really hard to understand what it might mean for a substitute decision maker to provide consent for somebody to engage in sexual activity, particularly or even what that would mean if the resident didn't seem particularly willing or interested in whatever the substitute decision maker consented to. So clearly that's not enough. Another challenge is that substitute decision makers are often family members. These could be a spouse or partner, or often adult children. So for one thing, especially if they're adult children, they may not know the past sexual wishes and beliefs of their parents. They may be uncomfortable discussing it, or they may have very strong opinions about what is appropriate kinds of sexual behavior based on their own notions, or have a loyalty, for example, to a past spouse or a past partner of the person they're making a decision for, especially if it's a parent. That can often lead to issues of overreach. So privacy is an obligation that care facilities do owe to residents. It is their home, and sexual expression is very private. And we know that family members tend to be far more involved in the sexual lives of residents than in many other areas, even though residents typically don't want family members involved in their sexual lives. Because we do have this kind of lack of policy, lack of support, lack of education often around sexual expression, what tends to happen though is substitute decision makers or family members get deferred to disproportionately in terms of making decisions about residents. And this is problematic when people in long-term care facility have reasonably limited spheres of control over their lives already. And it also tends to mean that the outcomes or the decisions made don't focus on the values of the resident as much as we might want, and tend to be based more on the values and wishes of other involved people like family members and often care providers as well. Another challenge is if predominantly the role of substitute decision makers is to represent the past known wishes, values, and beliefs of the adult, it's challenging to adopt that in the case of dementia, for example, when many of those values and preferences and behaviors may change. So this is a scenario I'm going to read out loud, and then I encourage you to take a moment to think about. So this is a female resident with moderate dementia. She's really happy. She's flirtatious with several residents and intimate with one. Her daughter is horrified by this behavior, says her mother was prim and proper her whole life, and wants the staff to stop her mother's behavior. In this case, there are a couple who've always had a really active sex life. Now the wife is in a facility with dementia, and the husband has continued to come and visit his wife. The wife seems distressed and ill at ease after these visits and becomes agitated in advance of his visits, and the spouse wants to continue. So in both of these scenarios, they're representing deviations from past behaviors. And when I present these in workshops with staff, they have usually fairly strong responses to when it's appropriate for them to intervene or not. So I think there are a couple of things for us to think about. Obviously, it's not only important to just make a decision based on previous behavior, because then we might not notice current harms. It's also important that we don't just respond disproportionately to current harms, that we also pay attention to benefits that are being experienced now as much, and not weigh the harms more than not worry as much about avoiding harms or preventing harms, that we also have to consider whether by intervening we're depriving people of benefit. Here's a third. There's a male resident who's been a strict lifelong vegetarian his whole life, and yet now he is in his dementia and is in long-term care asking for meatloaf, and it's his favorite day of the week that he looks forward to. And his wife is very concerned about this and has asked staff to stop serving it to him. In this scenario, when I ask staff, they almost universally say they would serve the son the meatloaf, and they often say they wouldn't mention it to the family if the family didn't already know about it. So I think this raises some interesting questions about our biases and our own values and how we are involving those, because in this case, this person's commitment or moral commitments to vegetarianism may be equally as strong to a different resident's past commitment to chastity or fidelity. And yet it seems like in some cases we hold moral commitments about sexuality to a different kind of standard. Further, it's not really clear what the value of consistency is with regards to sexual behaviors when adults throughout their lives are able to change values and preferences as they go through life and have different sorts of experiences. So I think it's worth talking about how much people should be held to past commitments that they no longer hold. And it's also, I think, important to consider what we're talking about in terms of harm. So in various consults that we have had as part of the ethics service and through my career is talking about different kinds of harms. And these include sometimes harms about reputation. So this may particularly be true in rural communities. If someone's exhibiting a very different behavior than they did in the community, or is exhibiting a sexual orientation, for example, that they didn't, there may be concerns from the family about how their loved one may be perceived as such information does seem to spread. And also potential harms. We also hear this risk quite often about family members saying, you know, if my mother, let's say in the first example, had a lucid moment, she would be horrified at how she was behaving. And often this is used as a reason to intervene in the behavior. And I think it's worth then thinking about, you know, how likely is that lucid moment to occur? What would be the severity of the harm to that individual? And what kinds of interventions that might be done to prevent that would be justified, or what harms might those create, and how would you weigh those? For instance, because of what we've talked about of the importance of sexual expression to identity and personhood, there are a number of harms, especially cumulative harms, of restricting sexual expression. So for one thing, you don't get the benefits of this sexual expression for health and well-being. It can also create loneliness, helplessness, and boredom. Depending on the temperament or reaction of the person, it could also increase frustration, distress, and anger. And these are sometimes treated with pharmaceuticals or antipsychotics, which have their own side effects and harms for the individual. Again, it may point to the intrusion or overreach into private life if people's sexual expression is continually denied, which can affect sense of self, agency, and personhood. It can also be quite challenging for care providers. Sometimes family members have suggested having security or asking a resident to move, or in some cases move facilities, which is quite challenging for the residents, especially when they have dementia. Getting used to a new place is very hard, but it can also be very difficult to staff to respond. So I think it's important to take another look at capacity and cognition. First of all, residents most likely have a much broader scope for capacity than they're typically granted or given credit for. This is partly because capacity, as we mentioned earlier, is decision specific. So if the decision is very complex and contains a lot of new information, like a surgery or an experimental treatment, then the threshold for capacity might be considered to be quite high. Sexual expression is often considered to be, or spoken about as being, one of the earliest learned behaviors. It's often very ingrained. It's something known to bodies, part of our emotion and who we are as people. And so if an activity has a very low risk and a very high benefit, then given a sort of sliding scale for capacity, we might also argue that the threshold for capacity would be very low. And so an individual, even with significant cognitive impairment or moderate cognitive impairment might still have the ability to make that decision or be allowed to make that kind of decision. The other thing too is just to remember, a lot of the concerns about abuse or exploitation have to do with sexual activity. And I want to just remind people that sexual expression is much, much broader than that. And not all forms of sexual expression might require consent. Forms of sexual expression like flirting or holding hands or hugging might not require that kind of standard. And often for many forms of sexual expression, it could be sufficient to express willingness or basically a lack of objection, or a willingness to be with that person, engage in that activity. And it's important to remember too that both assent and consent can all be expressed non-verbally. So we can judge a resident's willingness, even with capacity deficits, whether they're through their body language, through their demeanor, through their mood, through their actions. Are they seeking that person out? Are they flinching away? To see if they seem to be consenting or willing to be engaged in that activity. Thirdly, I think for people who maybe don't meet any of these standards or really do have significant cognitive impairments, it is important to think about how we can continue to support sexual expression for those individuals, given that we know how important sexual expression is to agency, to identity, and also these cumulative harms of having it be denied, even with people with cognitive impairments. Typically, guidelines that do exist have focused on trying to support residents where possible and just keeping an eye to what the risks might exist, both for that individual and particularly for others, to make sure that others also, if they are engaged in sexual interactions with another, that other person also has the ability to resist, is also willing to engage, and is also seeking out that behavior. And then there might be ways to mitigate that in a way that, again, brings the risks down to a point where we feel like this is at least a reasonable level of risk, because of course doesn't make sense to adopt no risk, since that would be a higher standard than the rest of the population. The other thing just to take another look at is this close connection that sexuality is associated with cognition. And you might argue, or it's probably commonly thought, that sexual expression isn't primarily a cognitive endeavor. It's something we feel with our emotions. It's maybe something we express through our bodies in terms of reaching out towards people, wanting to be near. The importance of touch, I think, has been very clearly identified. And so I think, and there has been some theorists out there talking more about sexuality in terms of being something more like dance or art or music, where we don't, it's not just rational through our heads, but more something that we can kind of express through, reaching out with our hands or a touch. And I think this also reflects the point of, if we associate sexuality too closely with cognition, that we are, by doing so, marginalizing the whole population of people who are therefore excluded from these forms of sexual expression. And it again doesn't reflect the rest of the population, where we are not always rational with sexual activity and don't always think of sexual expression as risks and benefits and consequences and alternatives, but more, which is exactly why you can't consent ahead of time for sexuality or consent for somebody else, because people change their minds and people often behave in inconsistent ways. And that standard, therefore, shouldn't be set to a degree that many people can't achieve it. That conversation is relevant to the conversation involving family members. Obviously, if people can make their own decisions with regards to sexual activity, or the risks are so low that it's felt that they are able to engage in those or assent and they're willing for sexual activities, it may affect the need to inform family members. And this part of respecting the obligation to privacy to residents. This is often challenging for care facilities, because there is a feeling that if they're not very transparent, that they're somehow hiding things. So this, I think, can be addressed very much through the creation of policies and telling family members up front that sexual expression takes place in care facilities, and this is when you'll be informed, and this is when you may not, especially if a resident is capable of making their own decision and doesn't want to inform you of that. So I think it's important that we be very deliberate about when family members or substitute decision makers are informed, to make sure that we have a reason for doing so and we know why we're asking them to be involved. And so rather than deferring out of lack of policy or lack of greater education or feeling nervous about and not including family members, I think the shared decision-making model, which we also use really commonly in healthcare, is really helpful, where both family members or decision makers have a role. In this case, the family member or decision maker can help share, again, what's important to that resident, what were their past values, wishes, and beliefs. They may help give some strategies for if a resident does need to be redirected, what would be an effective way of redirecting them in a respectful and non-judgmental way. And then staff are important for their part in terms of sharing their observations about how the resident is engaging in sexual activity, how they're interacting with a particular resident, and what the effects it seems to be on their mood, their quality of life. So kind of wrapping that all up, essentially, I propose that we need to change the narrative for sexuality in care facilities from one of a very cognitive model and a duty of protection, which essentially results in a model of prevention of sexual activity for many people, especially with cognitive deficits, to one more of upholding sexual rights for all persons, which recognizes that sexuality is a bit more complicated than just rational decision-making and does involve agency and sexual expression and kind of more other embodied elements, and reframe the question around how can we make safe sex safe and possible for this resident, rather than trying to limit or control sexual behavior. Obviously, in order to change the culture, care facilities have a big role in doing that. So I'm just going to summarize these pretty quickly. One is they do have an obligation, obviously, to protect the residents under their care, to make sure that nobody is subjected to unwanted sexual behavior, and also to see where they might be able to mitigate risks where that seems appropriate. There is an obligation to remove many of these barriers that we talked about in terms of setting the culture. This can be done with pamphlets. It can be done with an intake assessment. So where you might now ask in care facilities about people's hygiene needs or their favorite foods or their spiritual needs or grooming habits, you could also ask about sexual preferences and gender identity, and whether they have a partner that they may want to have visit them in the facility. Inclusive language should be used, could be demonstrated with posters to make people of all orientations feel comfortable and know that their own expressions will be accepted. And there's an obligation to support privacy, both of space, of body, and of information. Not just the negative rights or these attempts to remove barriers, there's also an obligation to promote opportunities for social connection, for engagement. This can be with dances, with social evenings, with opportunities for people to spend time together. And it's also worth noting that people of different abilities, physical abilities or others, may need help to achieve their sexual expression, which could include help undressing, help with positioning, help with setup, the provision of lubricants, to make sure that they are not restricted from engaging in sexual expression based on those characteristics. And then finally, we do need to develop policies so that both staff and family members and residents are more aware of how sexual expression will be addressed and what they can expect, which can help with these relationships and trust, both with all residents and family members. So in summary, sexual expression is central to humanness, health, and well-being, and isn't specific to cognitive status. Residents have broader decision-making authority than I think we typically recognize. Engaging in shared decision-making can help make sure that both staff and family members are involved in recognizing the range of values that are important, which include their past values, wishes, preferences, and as well as their current preferences, how that's affecting them, the risks and benefits of those, to make sure that the best decision is made for them that might most benefit them. The residents, obviously, values, wishes, preference, quality of life should be central, while recognizing that many of the people involved will have strong values and sometimes biases around matters of sexuality. And so hopefully by involving those two parties more in a shared decision-making model, it'll help to to counter some of those. And generally, we need to shift from a culture of protection to one of more support and enabling. And just the last thought, I think we've done a lot in society to recognize the importance of sexuality and sexual expression and to be more inclusive, although it seems that sexual expression in care facilities is a bit more lagging in this regard. The pandemic, I hope, has given us the experience of all of us of the importance of the need for human connection and touch and the harms of isolation and loneliness. So I'm hoping this will motivate everybody to work together to see how we can better support and enable meaningful sexual expression in care facilities. Sorry, that was a bit long. I have many the references. I will just end there. I didn't include all the references in the slides, but they're after this. So if anyone wanted those, I'm happy to share those afterwards. But I will stop now. So we have a few